We're going to look at these 2,000 TTAs. I suppose, like everything, we want to start by thinking about, well, why did we choose TTA in the first place? Clearly, we're happy with it. 2,000's a reasonable assertion of being quite happy with it. Why did we choose? So I suppose the first thing is, what is choice? You know, we make choices all the time. And it's basically a case of looking at the options you have, trying to work out what the advantages of one over the other are, and so on. So in one sense, you know, we do this with phones and cars and houses, and you've done it recently with presidents, and we did it recently and decided to leave the biggest economic market that there is in the world and go it alone as plucky Brits and so on. But sometimes choices are badly made, but choices made nonetheless. So what have we got in terms of a choice with regards to our kind of cruciate patients? What can we do? Well, we've got three main groups, don't we, with our thing. We can do intracapsular replacement. We've looked at some of the ones we have, extracapsular restraint, and then geometry modifications. So these are our three groups now. We have these bands that we can work with. So let's just kind of run through my thoughts on the options for intra and extracapsular at the time when we're making this choice. So my view is that patients who have extracapsular or intra-articular grafts are much more likely to spend their life in a way that they wouldn't necessarily choose. You know, they basically spend their time recovering from surgery. You know, 6, 7, 8 months maybe recovering from one surgery. They tend to have a protracted recovery. And so you have these patients where they have concurrent bilateral cruciate rupture. It's very, very difficult. Which one do you start with? And we have to remember that a year's recovery for a dog is a 12th of its life, maybe a 10th of its life. You know, that's a significant component of that life. So we kind of didn't like this technique. And also the thing with these techniques, I think, in our view, was that they tended to promote this massive degenerative joint disease. You know, these are osteophyte farms, essentially. So these are big, gnarly old joints that look horrible, feel horrible, and, you know, you don't want to see those patients again. And when you do that surgery, basically, you're going to end up using long-term non-steroidals. So they've spent a year getting over the surgery, and then they're going to spend the last 4 years of their life on NSAIDs, if they're lucky to have a little gap in between. But NSAIDs here, I think, really doesn't just stand for non-steroidal anti-inflammatories. I think really, in this case, it's that it's no substitute for a good intervention with a definitive solution. You know, so using poor surgical technique and kind of propping it up with some NSAIDs isn't a good approach for most of our patients. So what is a definitive solution then? You know, if we're going to look at this, if we're saying that, you know, that's no substitute, what is a definitive solution? Well, it should be one that meets our patients' needs. It should allow them to use the limb early, get these muscles activating early, reduce the likelihood of atrophy, keep this range of motion going within the joint, less kind of morbidity overall. And it should allow us, very importantly, to time our second intervention. These 9-month-old Labradors, where really one leg's as bad as the other and you're choosing which to do, you should be able to get on and get that dog back to recovery, an active lifestyle as quickly as possible. So that would define a definitive solution. And I think for us, the geometry modification options seem to address those things. Early use of the limb, and we could move on with the second limb without having to wait 6 months or so. So with geometry modification, we could kind of collapse this hurdle. We could make it such that cruciate disease was just a phase in that patient's life, and then they could carry on doing what they want to do. So geometry modification seemed to hit those markers. So if we look at the definitive solution then, early post-op use of the limb, appropriately timed intervention, but when we look between the two, TTA or TPLO, only TTA maintains this normal contact mechanic within the stifle from work that we're well aware of and has been discussed at length before. And this is important. This is really significantly important because if we look at our range of patients and look at the percentage and age, we'll see that 65%, more than, almost two-thirds of our patients, more than two-thirds of our patients are under 5 years of age. So if we're doing something which doesn't restore contact mechanics in young patients, then we might expect to see some problems because, as we know, incongruence plus time equals cartilage loss. It doesn't matter whether that's post-op incongruence or whether it's pathological incongruence. If you have an uneven joint load, you're going to lose cartilage. So this is a problem. You have 3-year-old dog, 2-year-old dog, 1-year-old dog, and we are in a position where we're inducing incongruence, and we should accept the consequences. So if TPLO, and I'm going to say this and then duck behind this podium, if TPLO is a prescription medicine, I think it would have to come with this warning that it's chondrotoxic and shouldn't be used in young patients. It's going to kill cartilage. So just like Baytril, it should be the same, TPLO. So we were delighted with the outcomes we were getting with TTA. We used TTA for those reasons, and we were enthusiastic. We saw these giant breed dogs. We had no cutoffs. Any dog, any breed, cruciate disease, we would do TTA. And these dogs weren't just using the limb well. They were using the joints well. This dog's bilateral and looks excellent. You can see the chondrocytes in there. They're still going to be there forever and a day. And this dog is moving beautifully. And, we were just absolutely over the moon. But we had to hold our hands up and say that things weren't all rosy in the garden. Not everything was going so well because we were all beginning to become aware that we were seeing some patients back. And we were seeing them back with one thing in particular. We were never seeing them back with hardware issues or with fractures or whatever. We were seeing late meniscal injury. So we were kind of worried about this. We looked at the numbers just to check to see that we were being accurate. And it's important to point out here, so the blue bar is total TTAs. But we must remember that if you have meniscal pathology at the time of surgery, you can't have late meniscal injury because it's been taken out. So the red bar is those that had a meniscus intact at the conclusion of surgery. And then the yellow bar is the late meniscal injury patients. So we were looking at a significant, like 28% of at-risk patients, so like 14, 15% of all patients. And that's where the data is quite difficult to work out because some papers quote of the total patient group and some people quite rightly indicate the percentage as a percentage of those who could have a late meniscal injury. So we were truly seeing patients back with this problem. So whenever that happens, you put the coffee machine on, you get the donuts out, and you all sit around and discuss what you're going to do. And we were throwing ideas backwards and forwards. And just like anywhere else, if you discuss late meniscal injury, someone is going to say meniscal release, as though this is what meniscal release is. We're freeing the meniscus to go and live another life, somewhere else, freed from the burden of sitting between the condyles, rather than just meniscal murder, which is essentially what it is. So we decided, well, let's not do that. Let's not reduce all of our patients down to meniscally deficient patients. Let's see if there's something else we can do. So we went back to the biomechanics and tried to understand what might be the source of this problem. And we thought, well, obviously, the whole point of this procedure is to restore stability to the knee by changing the geometry of the knee in a specific way. So a TTA is a TTA when it achieves this 90-degree relationship between straight patellar tendon and common tangent. That's what a TTA is, and anything that doesn't do that is not a TTA. So when we looked at the groups, where were we seeing these significant numbers? So I did a couple of things just to make the stats a little bit easier. So we took the plate as a size, that's determined by patient size, and then cage, and then took the ratio. So what was the ratio between plate and cage, just to give us a single figure. And we could see that we had these big clusters. We were pretty gentle with ourselves here. We were putting 3 cages in with 3 plates, 3s in with 4s, 5s and 6s, unheard of now, 6s and 6s, and these were the dogs that were getting a significant meniscal injury. So we kind of had a hypothesis that the high incidence of late meniscal injury was due to insufficient advancement. So if we have an unstable stifle and we do our surgery well, we should induce a stable stifle. If we do this, then we will have a happy meniscus, and if we take an unstable stifle and under-advance it, then we'll have an unhappy meniscus. So the idea was we were under-advancing. So we don't need to sacrifice all the meniscus in all of our patients. Let's see if we change our planning, change our application of technique, what do we do to late meniscal injury rate? So again, remember that this is percentage of at risk. The cage plate ratio, I've multiplied by 10 to get onto the slide. And so we pushed up to about 1.5. So at this point, we didn't have the 0.5s, so the 7.5s and so on. So this means that with a 6, we're always using a 9, minimum 9. So we're moving up to 1.5. Now we're at 9.7%. So we're at less than 5% of the total population. Simply by making that little adjustment. We've gone from 25% to this 10%, which we were quite happy with. So was that the problem solved? Was it just a case of pushing that on? Well, I kept an eye on the data and made sure that things were going okay, and it became clear that we were back in the problem zone again. So perhaps we were wrong. Maybe this was just a phase that was to do with learning curve rather than advancement. But actually what we had done was it made an adjustment based on our experience with low cages. So we were placing these cages quite low to try and squeeze as much advancement out of them as possible. And then we got tibial tuberosity fracture. And so we decided to push our cages up. And as we pushed our cages up, of course, we lost advancement, because if you look at the relative position of the cage, it's going to have a different power with regards to advancement. So the same size cage, higher up, is a smaller cage, essentially. So we changed our templating method. We looked at a different way of thinking about the cage. The 9mm cage is only delivering 6.9, subtract the kerf and so on, and that this is going to be delivered down at the crest, so we used bigger cages again. We started to think about this line A as the arbiter of the cage size and not line B. So our cage sizes went back up again. So as a result of that, we came down to, like strictly speaking, 2.5% of all patients, so 5% of the at-risk patients. We'd pushed on up to like this almost 18 mark as the plate-to-cage ratio on average. So again, a very low meniscal rate. And that has been consistent. We're now 3-4% year on year. The one thing that I will say is that and I don't quite understand this, is that we are seeing some very late meniscal injuries. So dogs coming back 2 years later. We're only talking about 2 or 3 patients, but coming back 2 years later with a meniscal injury, which is interesting. So as we've pushed the advancement up, we're maybe still picking up some of these dogs that in deep flexion or they're doing something posturally are still able to injure the meniscus. So basically, that was our main problem, because if we look at the other things that we hear about when we look at papers on TTA, these are the big disasters. You know, late meniscal injury, it's second surgery, but it's fairly straightforward. You're going in and you're removing, the meniscus. But we were trying to preserve them, which is why we tried so hard. But of these 2,000 TTAs, 1 tibial diaphyseal fracture. And the reason for that was because someone broke their drill bit and then redirected the screw. So that was a technical error that led to that 1 diaphyseal fracture. 1 crest fracture, 10 tuberosity fractures, and we had 3 patellar luxations in the early group. We haven't seen any of those since. Tend to use the washer. That's the other thing that in my surgeries, I'll put the 4mm spacer in every single dog that I do. And we've had 10 septic arthritis cases. No implant-associated infection. These were intra-articular and a long time after surgery. So basically, TTA is like an Apple computer. It just works, you know? It does what it's meant to do, more or less, as long as you know how to use the thing, you know? That's the way we felt about TTA. So briefly going back to this idea of choice then. This is our job. We have to choose the most effective method for making our patients as well as they possibly can be with whatever disease they present to us with. And so within the context of this, we're looking for a method that allows us to deal with this difficult, enigmatic process of cruciate deficiency, which is a degenerative disease, it would seem, may well be to do with morphology, maybe even non-isometric cruciates and so on. And this isn't easy, you know? It's not easy to actually choose the most effective therapeutic mechanism. And this is a phrase by Atul Gawande from his book Complications. And it's this horrible phrase here. Every new treatment has gaping unknowns, and it can be hard to decide what to do about them. And if we're honest with ourselves, there are gaping unknowns. We don't actually really know how TTA switches lameness off, or how TPLO switches lameness off. You know, why do these dogs present 9/10 lame, and within 2 days of surgery are 3 to 4/10 lame? You know, if they're still unstable, as has been said, why are they so inclined to do this? Where is the right balance in terms of what we should be doing for these patients? And this is difficult because essentially we have our patient and our owner sitting in front of us, and we have to behave as an authoritarian. We have to say, you know, what can you do for my dog then? Well, I'm not sure, you know. It's just these gaping unknowns. I don't know how to deal with those, you know. And it's difficult. So we tend to have to decide on which bandwagon we're going to hitch our truck to and run with it and try to improve with it, which explains obviously why people still do TPLO. But essentially, if we think about it, you know, a pet plus a problem equals a patient. It's straightforward, just like a person plus a problem equals a patient. So all we need to do is this simple bit of maths, actually, because a pet equals a patient minus a problem. All we have to do is subtract the problem and not leave any behind. So we need this problem extractor. We need to be able to put our patients in one end and get pets out the other end. This is what we're trying to achieve in all medicine, is to extract problems from our patients, because that will allow them then to be individuals again, free of disease. And for us, I would say that a Kyon TTA is the problem extractor in our hands. You know, when we do TTA, it extracts the problem of cruciate disease. These dogs can go on and lead a proper, normal life, free from requiring non-steroidals, not having constant activity restrictions, and so on. So this then leads on to this last section. What about all these high complication rates? You know, where does that come from? Because what we've just established is that there's nothing intrinsically risky or complicated about TTA. If it was, then no one would be able to do it with a low complication rate. But what we're seeing is that some people who, unlike most surgeons, have managed to suppress their ego well enough to put their hands up and say, I'm rubbish at TTA. Because that's what they're saying. The only alternative is that TTA is rubbish. We've just established it's not. So what these surgeons are saying is, I can't do TTAs, which is really brave of them and very, very unusual. And it should be commended that they're willing to own up to their inability to perform this quite simple technique. And, you know, one of the choices, you know, maybe they're just doing it wrong, you know? This is not Photoshop. This says, go on a course, doesn't it? You know, if you need an X-ray, you know, what do you think? I think that cage could be a bit bigger, don't you think? But, I mean, come on, really. And we never see post-op radiographs in these, you know, case studies where they've got 65 TTAs or 18 TTAs. You know, they never put radiographs on there to show us what happened, how the surgery was executed. We're never very sure what the training status was. So you must be doing it wrong, because it can be done well. And the only other option is that maybe there's another agenda. And this is a model bad paper that should never have been published, the TTA versus tightrope versus TPLO paper, where 18 TTAs are compared with 65 TPLOs and 3 million tightropes. And then it's established that TTA is a poor technique. And I think that's kind of one of the difficult parts here, is that there is no reason to report high complication rate unless you are accepting that you as an individual are unable to do the procedure. It is possible to do well. And we're all allowed to make mistakes. You know, we do make mistakes, but we shouldn't then make them an inherent part of the procedure if it's not the case. We should be scientific, we should be honest with ourselves and say, that's just not the technique for me, and I can't be bothered going on a course, or I want to sell more of my technique, and therefore I'm going to publish a paper that shows that this is a poor technique. So basically, we do make mistakes, we look at things in the wrong way, and so on. And that happens in many walks of life. Okay. Thank you. Thank you.